Welcome to today's Satellite Symposium, supported by an educational grant from Mallinckrodt, Advances in Predicting and Managing Renal Dysfunction in Liver Transplantation. Today's moderators are David Foley and Michael Chris. Today's session speakers are Mitra Nadim from the University of Southern California, Dean Carvelis from University of Alberta, and Josh Levitsky from Northwestern University. Please stay tuned after the session talks for the panel discussion. If you would like to submit a question directly to our session moderators, please utilize the Q&A feature on the side panel of your screen. Enjoy the session.
Good morning, good afternoon, good evening, depending on where you are watching this at this time. I'd like to thank the organizers of the meeting for inviting me today to talk about acute kidney injury in patients awaiting liver transplantation. This is my disclosures. So if you look at the epidemiology of AKI in patients who are hospitalized with cirrhosis over the past 15 years, there's an increase in the prevalence of AKI, and this partially has to do with the changing population. There are more patients with NASH cirrhosis who are being admitted for various reasons, whether it's transplant workup or complications of cirrhosis. And part of this also has to do probably from the changing definition of AKI. If you look at over the past really 50 years, prior to 2012, there was no definition for AKI. All the definitions for kidney injury was only related to patients who had hepatorenal syndrome. There was definition of HRS that came out in 1979 initially, and this was further modified by the International Club of Ascites. It was the criteria was proposed modified version in 1996, then updated in 2007. And again, as I mentioned, it really wasn't until 2012 where the Acute Disease Quality Initiative group, along with the International Club of Ascites, came up with actual definitions for AKI. And this was then modified in 2015. So as I mentioned, if you look back, on the left was the ATKI group. Again, this was in collaboration with the International Club of Ascites. And what we had proposed at that time was that AKI to be defined based on the Aiken criteria. The KDIGO criteria did not exist at that time. And it was basically to state that to remove the serum creatinine of 1.5 and use this, really the definition that existed, which was a change in serum creatinine of 0.3 within a 48-hour period, or 50% increase from baseline. And what we propose is that the HRS type 1 should be considered a specific form of AKI. This was then slightly modified, really very similar. The KDIGO guidelines, the only difference was that the 50% increase was presumed to have happened in a 7-day period. The International Club of Ascites added a baseline serum creatinine definition. But as you can see, neither of these included the urine output definition for AKI, which existed both in the Aiken criteria and the KDIGO. And the thought was by many of the members of the International Club of Ascites that urine output is very difficult to measure in these patient population, and they felt that at this time not to include it in the definition. However, this is the largest study. It was a retrospective study by University of Pittsburgh in 8 of their intensive care units. Is close to 4,000 patients who had liver cirrhosis who were admitted to these hospitals. And what they found is that if patients had no definition of AKI based on serum creatinine, but they did meet the urine output criteria based on the KDIGO criteria for stage 3, that their mortality actually was much higher than if they had no AKI based on urine output criteria, but based on serum creatinine only. And if the two were together, the mortality was quite high. So if you look at the guidelines that have been published now, EASL, both the European and the American ASLD guidelines still do not include the urine output criteria, but they do have some clauses to suggest that urine outputs are important. And in the EASL guideline, there's a statement saying it should be highlighted that the KDIGO criteria is based on urine output also, and these criteria may be applied whenever a patient with cirrhosis requires a bladder catheter. Basically saying that if you can measure the urine output, then it should be considered. In the ASLD guidelines, there's a statement stating that measurement of the urine volume, a component in the diagnosis of AKI, is important because oliguria is associated with poor prognosis. What about the workup? So the workup for these patients, again, as a nephrologist, we go through the algorithm of pre-renal, renal, post-renal. And again, I'm not going to go into all these details, but very important to always go through that algorithm. You don't want to be missing if it's drug-induced ATN or acute interstitial nephritis, if they have a glomerular disease. But what it all comes down to is trying to differentiate between hepatorenal and ATN. Initially, when they are volume depleted, we try to differentiate with hepatorenal. And again, even though the HRS guideline, the International Club of Ascites guidelines for definition of HRS has excluded, excuse me, the serum creatinine, but it requires this 25% albumin. However, my thoughts are really, and this was published in a review article, is that if a patient's truly volume depleted, where there's no edema, you know that they were over diuresed, that they have diarrhea, give them crystalloid or 5% albumin. In contrast to 25% albumin in those patients where it's sometimes hard to determine what their fluid status is. Again, a lot of times they may be they have total body anosarca. Yes, the intravascular may be slightly dry in those patients. However, giving too much albumin can have consequences. Excuse me. And if within 24, 48 hours, the AKI doesn't resolve, we're left again trying to determine HRS versus ATN. Again, this is to show that we should not forget about underlying kidney disease that these patients may have. A lot of patients now have NASH cirrhosis, they have diabetes, they may have diabetic nephropathy, there's medications that can cause ATN, and again, the glomerular diseases should be always at the back of our mind when we're evaluating these patients. But as I mentioned, it is very difficult trying to differentiate HRS for ATN, and it is a diagnosis of exclusion. And concern is treating the right patient and knowing what to, who has the HRS and who has ATN. But it's not as simple as we think it is. So if you look at, there have been several studies over the past really 20, 30 years looking at kidney biopsy and correlating that with urine, either indices or urine analysis. And again, there's very few studies because not many people do a biopsy on these patients, but there's a poor correlation between kidney function, urine analysis, and your biopsy. And again, these studies have shown that there are several patients who have normal UA with abnormal findings on biopsy. But one that they also showed in these biopsy studies was that the fractional excretion of sodium can be low in patients with ATN. And this is a study, the first study also looking at this, the TRIBE AKI, was from out of Yale. These were not biopsy-proven studies, patients. But what they looked at, they compared various biomarkers and they compared it to the clinical presentation. The physicians decided whether they have ATN or HRS or pre-renal. And they also looked at the fractional excretion of sodium. And if you can see here, the fractional excretion of sodium of all of it was less than 1%, but patients with HRS were extremely low, as low as 0.1%. Again, in our institution, the urine sodium, anything less than 20 is report is less than 20, so we really cannot even measure FeNA to say is it 0.1 versus 0.3. But if you can, the suggestion is that if it's really, really low, it's possibly HRS. But this is, shows similar to those kidney biopsy studies that ATN, you can have patients with ATN with low FeNA. And this was recently published in Kidney 360. And this is not in cirrhotic patients, this is all comers. But what it shows is that if you look at the urine sediment, and unfortunately that's an art that many of us are forgetting. Many nephrologists, we don't have time to go down to the lab. A lot of labs don't even let us go in there to spin the urine. But if you do spin the urine, what this study has shown is that even in patients who have more than 50% muddy brown granular cast, where we would definitely say this patient has ATN, you can see here about 36% of those patients had a fractional excretion of sodium of less than 1%. So we really can't, put all our money on the fact that if someone has a low FeNA, this is HRS and not ATN. And even if you have a mild amount of granular cast, which we used to say if you see it, it's definitely ATN, you can see here a huge percentage of those patients had fractional excretion less than 1%. So what about prior to developing AKI? The main thing is, can we prevent it? I'm not going to go through these details, but the main thing is trying to prevent the development of HRS with antibiotic prophylaxis for GI bleed or SBP patients, judicious use of diuretics, trying to avoid some what we call nephrotoxic, but in this day and age, everything is considered nephrotoxic. PPIs can cause kidney disease. You have a lot of these patients on vancomycin, Zosyn, which can cause kidney disease. And the radiocontrast, a lot of them require this for transplant eval. So again, we try to minimize these, but again, some of this is very difficult in a patient who is being evaluated for liver transplantation. What about the treatment? Excuse me. In the US, we only have midodrine and octreotide and norepinephrine as a treatment. In countries in Europe, terlipressin. In Australia, terlipressin is available. These are vasoconstrictors that are used for the treatment of hepatorenal, and all of these are given in combination with albumin. The midodrine is something that we use often, only because it can be given on the floor versus norepinephrine, which requires a transfer to the ICU. And what about the studies? Well, there's been a lot of studies over the years, 3 large ones in the US, but the most of the studies have been with terlipressin, comparing it to the placebo, which was albumin. There's a few studies you can see here. The larger the circle, the more studies there are. With norepinephrine, there's 10 studies, but really very few with midodrine octreotide. This was the final. This is the final study that came out in the U.S. and then the third trial in the U.S. in the New England Journal was published last year, looking at terlipressin plus albumin versus albumin. It's the largest randomized trial ever done on terlipressin, and although again, as expected, they did not find any survival benefit, because again, at the end of the day, these patients need to be transplanted. What they did find was that there was a statistically significant improvement in renal function and reversal of HRS. What about side effects? Unfortunately, patients who were in the terlipressin arm had higher respiratory failure. There was higher death, and it had to do all with respiratory failure. And the risk factors were higher MELD, baseline grade 3 hepatic encephalopathy, ACLF, and previous history of cardiopulmonary disease. And because of these, because of this higher mortality for now, FDA has not approved of this medication in the US, and it's still going under discussions with the FDA. What about terlipressin, how it compares to norepinephrine? In the past, studies have shown no difference. This is the first study in patients with ACLF where it showed that patients who received terlipressin actually did better in terms of reversal of HRS. What about after transplant? Well, this is the only study looking at the incidence of CKD in those patients who responded to treatment. They actually did better post-liver transplantation. Their survival was much better, but more importantly, the incidence of CKD was less. So again, going into transplant without AKI, these patients tended to do better. Excuse me. What about the effect of norepinephrine outside of the ICU? Because that is one of the limitations in the US. This is a study out of Stanford. They used norepinephrine in patients with HRS outside the ICU, but it seems like it was in between a ward and an ICU setting, more like a step down. And even though they at the end concluded that this is feasible, if you look at it, it required significant amount of monitoring every 15 minutes, something that's not done in a step down units, and about a fourth of those patients had adverse reactions. So I suspect that for most hospitals in the US, the use of norepinephrine outside of the ICU will not be happening. Now I'm going to, a few slides at the end to talk about what about dialysis. In my region in Los Angeles, we have a very high MELD region. So often patients are on antibiotics, pressors, TPN, they may be ventilated, they're frequently on CRT, and we have to decide whether or not we should offer dialysis in these patients. In the past, people have felt that if your MELD is very high, your outcome is poor. This is a study we looked at several years ago. It's a UNOS database in patients who we uncapped the MELD. And really, this study should push for the uncapping of the MELD because the MELD was arbitrarily capped at 40 with the idea that anyone over 40 really would be futile. But now 20 years out of the MELD, we all are now transplanting patients way above the MELD of 40, but unfortunately, patients with MELD 40 and 45 and 50 are capped the same. What we showed is that on the wait list, as expected, their mortality is high, the higher the MELD, and however, if transplanted, their outcome is exactly the same as a MELD 40. And again, this is something that suggests that maybe the MELD should be uncapped and be used what it was first developed for, which was the idea of patients to show acuity pre-transplant on the wait list. The higher the MELD, the higher your mortality. So a lot of programs are looking into, not so much whether or not to dialyze a patient, but their ACLF. And if they have ACLF 3 and by day 5 or 7, if they still have three or four more organ failures, well, their outcome is poor, and maybe to have a different discussion with the family. But even if they come very sick by day 5 or 7, if they turn around the corner and now they only have 1 or 2 organ failures, you can see here their mortality is close to 0. So again, maybe to use these metrics instead of transplant candidacy, whether to list a patient, whether to start dialysis. In the past, people have used the presence, whether the patient has HRS or ATN, as a way of deciding whether or not to start dialysis. This is a study retrospective from the Mass General showing, well, no, if clinically you decide HRS or ATN, they both, if they end up on dialysis, if they're not listed, their outcome is poor as expected. But if they are listed, again, a percentage of them, about 40–50% die, but there's no difference depending on the etiology. And this is a study from our center, which we showed that once you transplant these patients, again, the HRS patients actually do extremely well. And it's the patients with ATN who have this lingering chronic kidney disease and a worse survival outcome. So what does the society say? Well, the European Society, on the left, this is a multi-center, multidisciplinary consensus meeting that was organized and included hepatologists and intensivists and nephrologists. And what we suggested is that you should start it based on clinical grounds, worsening AKI, worsening volume overload. And even if you're non-oliguric, if your daily fluid balance is more than what you can is remains positive and you can't maintain your daily fluid intake, that patient should be started. The ASLD guidelines that recently came out also states that it should be used in candidates for worsening renal function, electrolytes, and if they're not a candidate, then again you have to have a family discussion, but not to hold dialysis based on the etiology. And at the end, really, it's a multidisciplinary approach between the hepatologists, the surgeons, nephrologists, intensive, especially if they're in the ICU. It's mandatory to figure out which patients are high risk for mortality and to examine ways to extend life until transplantation is possible. Thank you very much.
Hi, my name is Constantine Carvelis, and I practice critical care and hepatology at the University of Alberta in Edmonton, Canada. And it's a pleasure to discuss managing and predicting renal dysfunction and recovery in the peri-transplant period at this exciting session at the cutting edge of liver transplantation. So the objectives of this talk are to review risk factors for acute kidney injury and chronic kidney disease post-liver transplant, review predictors of renal recovery of those with AKI, approaches to immunosuppression that may facilitate renal recovery post-transplant, and review current accepted recommendations regarding the timing of combined liver-kidney transplant. So as you may be aware from the previous lectures today, there's been harmonization with regards to the definitions of the different stages of acute kidney injury between the critical care, nephrology, and cirrhosis literature, most recently with the International Club of Ascites adopting the definitions of stage 1, 2, and 3 acute kidney injury in cirrhosis. So regarding pre-liver transplant factors associated with the development of AKI post-transplant, it makes logical sense that having pre-transplant AKI or chronic kidney disease would be significantly associated with this. But there are other factors, including obesity, hypertension, diabetes, and specific etiologies, including viral hepatitis, alcohol, and hepatocellular carcinoma. The etiology of acute kidney injury also has specific impacts on the development of chronic kidney disease post-transplant and also post-transplant survival. And most importantly, while the current line of thought is hepatorenal syndrome tends to potentially be reversible with liver transplant, established ATN does not and portends a higher probability of chronic kidney disease post-transplant, and furthermore, a lower survival after transplant. So there are also severity of illness factors that have been well documented to be associated with post-liver transplant AKI as well. And this is really irrespective of whether you use liver-specific scores such as the MELD or the sodium MELD score, factors such as lactate reflecting poor perfusion, high-grade hepatic encephalopathy, or the number of organ failures as reflected by some of the definitions of acute on chronic liver failure, specifically being with increasing grades of ACLF or increasing numbers of organ failure being associated with a higher probability of post-transplant AKI. So this is just to give you an idea of probably the most commonly used definition of acute on chronic liver failure, and this is the CLIF definition, which defines 6 different organ failures, including liver, renal, neurologic, coagulation, circulatory, and respiratory. There are also donor factors that one needs to keep into account. So this includes a donor age of greater than 60, a donor BMI of greater than 30, or specifically graft steatosis, which can be associated with obesity, ABO incompatible grafts, which are used in parts of the world where they rely predominantly on live donor transplant, a prolonged cold or warm ischemia time at the time of organ procurement, and finally donation after cardiac death. So this was an interesting study by Lighthead and colleagues from Birmingham, where they looked at 1,150 transplant patients between 2000 and 2011. And they were able to demonstrate, after adjusting for significant covariates, specifically that a longer warm ischemia time, a deceased cardiac donor, a donor age of greater than 60, and a donor BMI of greater than 30 were all independently associated with a higher probability of AKI post-transplant. Furthermore, the study from Korea, where it was more common to use almost exclusively live donor liver transplantation, demonstrated that in the setting of using ABO incompatible grafts versus ABO compatible grafts, those patients that received live donor ABO incompatible transplants were more likely to develop certainly stage 1 AKI after transplant. There are also significant intraoperative factors. Some of these can be predicted by the fact that a more critically ill patient going in for transplant likely will need more significant resuscitation. However, these specific factors, which are illustrated nicely in this study by Tokade and colleagues, show that intraoperative hypotension, whether this being reflected by increasing vasopressor requirements, or those specifically meeting the definition for forced perfusion syndrome, which was a drop in MAP by greater than 30% at the time of unclamping, was associated with higher rates of AKI. Also, either increased blood loss and concomitant rates of increasing requirements for blood transfusion, oliguria, and then also surgical factors such as cable replacement or increasing duration of the anhepatic phase were associated with higher rates of AKI. One of the things specifically that these can lead to is the phenomenon of hepatic ischemia reperfusion injury. And this study also demonstrated a significant association between the severity of hepatic ischemia reperfusion injury and the development of moderate and severe acute kidney injury. So certainly in those patients with severe HIRI, specifically a peak AST of greater than 5,000, had a significantly higher rate of both stage 2 and 3 AKI compared to moderate or patients without any hepatic ischemia reperfusion injury. And then we're well aware of the post-transplant factors that often we attempt to mitigate in the ICU setting after transplant. So we know specifically that calcineurin inhibitors can exacerbate acute kidney injury. We try to avoid the use of nephrotoxic medications. Using normal saline, which in high volumes can cause a hyperchloremic acidosis, can exacerbate AKI. Unnecessary diuretic use. Post-operative infections are associated with an increasing rate of AKI, and increasing requirements in ICU and certainly for mechanical ventilation, which this once again might be reflecting a sicker patient, are also associated with higher rates of post-transplant AKI. So when looking at all these factors, what are the things that we can do to either prevent AKI in the first place or try to mitigate AKI in the peri-transplant setting? So certainly in the pre-transplant setting, we try to reverse AKI through volume expansion, whether that be with albumin or crystalloid solutions. Specifically for HRS type AKI, we use vasoconstricting agents like midodrine and potentially terlipressin if you're in Europe in the ward setting in combination with albumin. Or if you're in the ICU setting, it would be a vasoconstricting agent like norepinephrine along with albumin. The role of renal replacement therapy, apart from preconditioning a patient for transplant, is an area of equipoise. But we certainly know that if we treat organ complications of cirrhosis, and specifically acute or chronic liver failure, that generally that patients that have improvements in organ function have better outcomes and lower rates of post-transplant AKI. So this was a study by Boyer and colleagues from a few years ago that demonstrated, was looking at patients who received terlipressin compared with placebo. And it demonstrated that irrespective of whether you got terlipressin or not, if you got a complete response, specifically with an improvement or in your renal function, even in the absence of transplant, you had an improvement in short-term survival. And certainly this kind of illustrates the fact that if you're going into transplant with normal renal function, you're more likely to be not only a simpler patient to get through transplant, but you might be able to start appropriate immunosuppression with calcineurin inhibitors earlier in the post-transplant phase. With regards to renal replacement therapy, there is a lot of equipoise regarding a variety of different factors. So the timing of initiation, whether to do it early versus late, while there hasn't been a specific study looking specifically at cirrhotic patients, there were patients with cirrhosis in the larger START AKI critically ill study, which did not demonstrate a benefit to the early use of renal replacement therapy. However, generally at this point, we know that there is benefits of pre-conditioning or using renal replacement therapy in patients with AKI pre-transplant, because you can mitigate volume overload, you can dry the patient out somewhat, you can improve acidosis and drive down hyperkalemia to make their journey through the operating theater and transplant easier. To this point, in terms of the specific modality, we tend to use continuous modes in patients that are hemodynamically unstable. And then the question of anticoagulation with a simpler mode like continuous veno-venous hemofiltration, often we can get away without exposing the patient or the circuit to anticoagulation. Where more complex modes like continuous veno-venous hemodiafiltration, you might need to use some form of anticoagulation to prevent the filter from clotting. As mentioned before, in patients with acute on chronic liver failure and multi-organ failure, generally if you can intervene in the ICU setting pre-transplant, and improve the burden of organ failure, generally not only the probability of AKI post-transplant, but also overall patient survival improves. And this was a nice study by Vinay Sundaram and colleagues looking at the UNOS registry that demonstrate if you took a patient with 3 or more organ failures, or ACLF grade 3, at the time of ICU admission, and if you were able to downstage them to 0 to 2 organ failures at the time of transplant, their outcomes were fairly similar to a patient that was a grade 0 to 2 ACLF, either on ICU admission or at the time of transplant de novo. So in terms of intraoperative considerations, we try to avoid hypotension using crystalloid albumin, blood products, and vasopressors. However, as mentioned before, often the requirement for resuscitation intraoperatively can be more prognostic, in that more severely ill patients preoperatively require more intraoperative support. I qualify that I'm not a surgeon, so I'm not an expert with regards to surgical technique, but there is some data that some techniques, such as the utilization of venovenous bypass, may potentially decrease rates of AKI post-transplant. And I will mention a little bit on intraoperative renal replacement therapy, because while there are a few studies of retrospective data on this, there is a paucity of data in good prospective randomized data. So this was the Inception study. It was a pilot study that we did at our institution at the University of Alberta in Edmonton. And essentially, I would say it was a cautionary tale. We had to screen a variety of patients to end up randomizing 32 patients either to standard of care, which included renal replacement therapy prior to transplant, versus those that received intraoperative renal replacement therapy. And it should be noted that after randomization, 7 patients that had been initially randomized to the standard of care arm ended up crossing over and receiving intraoperative CRT, largely due to a series of predefined indications such as volume overload and acidosis. So in general, if we looked for protocol at the actual treatment that the patient received, there were no statistically significant differences in overall survival and dialysis dependence. However, there was a slight improvement in renal function 6 months post-transplant in those patients that received intraoperative renal replacement therapy. But as you can see, based on the numbers and a lot of the challenges with regards to randomization, there still really remains equipoise with regards to intraoperative renal replacement therapy. In terms of postoperative considerations, ensure adequate fluid resuscitation. In the ICU setting, we often do this with dynamic techniques such as bedside echocardiography and following the lactate. We try to delay or minimize calcineurin inhibitor exposure in the early post-transplant phase. If you have somebody with persistent AKI, you can consider additional doses of anti-IL-2 antibodies or using an mTOR inhibitor such as sirolimus. Minimization of CNIs has been associated with improved renal function in several studies and has not been associated with increasing rates of acute cellular rejection or mortality. And I just highlight here some of the studies that have looked at this that generally have shown favorable outcomes when you do this. Finally, I would just mention, when considering a combined liver kidney transplant, either in the setting of a sequential or a simultaneous transplant, there was a recent set of UNOS criteria that was defined in a study by Formica and colleagues, where they defined this as, and really the question here is trying to differentiate between somebody that has hepatorenal syndrome where there still is some reversibility with truly well-established ATN. And based on the definitions of either 6 weeks requirement of renal replacement therapy, which is a human decision, or a 6-week period of a GFR of less than 25 ml per minute, or any combination of the two reaching 6 weeks, they went into the UNOS registry and stratified patients based on this. And in those patients meeting these quote unquote renal failure criteria, those patients that ended up getting a combined liver kidney transplant had a better outcome with a p-value of less than 0.001. Interestingly, in those patients that didn't meet the 6 weeks of either requirements for renal replacement therapy or a GFR of less than 25, patients that received a combined liver kidney transplant actually had a worse outcome, interestingly enough, although the numerical difference was small, it was statistically significant. So in summary, acute kidney injury is common post-transplant and negatively impacts patient outcomes. It's associated with higher rates of chronic kidney disease post-transplant and decreased rates of patient and graft survival, specifically with ATN. Optimization of the patient pre-transplant includes treating HRS, specifically HRS AKI, with volume resuscitation and vasoconstricting therapies. Improvement in the degree of organ failure pre-transplant is associated with improved post-transplant renal and patient outcomes. Donor characteristics should be considered carefully when considering liver transplant in an ACLF patient with AKI, or as the adage goes, marginal donor with a marginal recipient leads to marginal outcomes. And delayed introduction of calcineurin inhibitor therapy has been associated with improved renal recovery in patients with pre-transplant AKI. And finally, consider combined liver kidney transplant in patients with AKI with any combination of either a GFR of less than 25 mils per minute or requirement for renal replacement therapy for greater than 6 consecutive weeks. Thank you very much for your attention.
Hi, everyone. I'm Josh Levitsky. I'm a professor of medicine at Northwestern University Feinberg School of Medicine and a transplant hepatologist. Today, I'll be talking about next steps in accurately predicting and managing renal dysfunction in liver transplant recipients. These are my disclosures. So I'm going to basically be breaking it down into 3 areas. Why do we worry about renal dysfunction in liver transplant recipients? Is there any way to predict this so that we could have more proactive measures up front to avoid renal dysfunction? And then I'll talk about some specific management strategies that are immunosuppression or non-immunosuppression based that could help prevent, to some degree, kidney deterioration after transplantation. So first, the main question is, why do we care about kidney injury in transplant candidates? Well, there's a mortality related to kidney injury in patients waiting for transplant on the wait list. This is why it's included in the MELD score. It's a predictor of mortality. And this can progress to irreversible injury. At some point, there's a tipping point where the kidneys are not going to recover after liver transplant. And I'll be talking a little bit about this later, but it's very difficult to determine even with the best clinical criteria. And then patients who have prolonged kidney injury after liver transplant, whether they require dialysis or come off dialysis, but still have kidney dysfunction and develop CKD, this is highly associated with morbidity and mortality. So kidney injury is very central to outcomes of pre and post liver transplant patients. These are some old data, but the initial results had shown that patient survival after liver transplant is significantly reduced if patients need dialysis afterwards. So as you can see here, doing a liver transplant with a kidney transplant, the survival is very good. If you need dialysis, the survival drops significantly with prolonged dialysis. So we try to avoid dialysis post liver transplant alone if we can. And this is another study early on showing survival in liver transplant recipients is really tied to whether they need renal replacement therapy or not. Hemodialysis or CRRT is associated with significant reduced survival compared to patients who do not need RRT. And so this is, you can see the real differences here based on their kidney function on how they're going to survive. And it may be actually the degree of renal failure pre-transplant that may predict who may recover or not in their survival. And so if you don't have dialysis, this is comparing a liver kidney group versus a liver transplant alone. The liver kidney group still does better with than the liver transplant alone group, probably because we are, even though there's no dialysis, we're avoiding or reducing post-transplant kidney dysfunction. But if you require dialysis for up to 4 weeks before a liver transplant, your survival is also diminished compared to those who have received a liver kidney transplant. So clearly the kidney function is central, is a big part of these patients' survival in this perioperative and postoperative setting. And so this has, because of this fear, because we're worried about patients having prolonged kidney dysfunction after a liver transplant alone and difficulties in predicting it, we all know that the liver kidney numbers significantly increased over time up until about 2017 when the new UNOS policy was introduced. So I'm going to go over that in a minute, but certainly you can see the rise here was taking kidneys away from the kidney transplant patients or kidney transplant candidates, and it was a problem there that there was, again, taking from that pool, but taking away from the kidney transplant pool. And so I'm not going to go through all of the criteria, but once the criteria were established, one can see that the registrations stabilized, they came down, and they have started to inch up a bit, but still have remained below the number of liver kidney transplants we performed before the 2017 criteria. So it has had some benefit in not allowing it to increase like the trajectory it was before 2017. The downside, as well, it was put in into the protocol that if patients didn't recover after a liver transplant alone, they could be a candidate for a safety net, a kidney after a liver transplant. And you can see on the bottom that since the SLK criteria were put into place, which has some more stringency and rules, kidney after liver transplant listings and per transplants have gone up. They're not very high numbers, but they've essentially nearly quadrupled. So this does use a kidney off a kidney transplant list, although balance still overall is slightly in favor of sparing some kidneys and also not allowing the significant rise in SLK transplants that was going on before. Just showing this graph here again, renal disease after liver transplant. This is an old slide. This is something we really want to avoid. Liver has one of the highest rates of renal dysfunction after transplant. And really, how do we sort of predict this? There are some clinical models that have been used, but it's very hard to predict based on levels of immunosuppression, presence of comorbidities like age, diabetes, pre-existing kidney dysfunction. In fact, pre-transplant kidney dysfunction is actually probably the #1 predictor of long-term post-transplant kidney function. So if you're going into the transplant with kidney dysfunction, you have a higher risk of having it long-term. Now, there's some patients who have recovery of renal dysfunction, but then because of calcineurin inhibitors have progression over time. And here I should show you a table of different biomarkers that have been used in the perioperative and postoperative setting to be able to estimate or predict the risk of developing chronic kidney disease after a liver transplant. Why is this important? Well, if we had some better markers, we could perhaps modify immunosuppression to particularly CNI withdrawal or conversion to an mTOR inhibitor to potentially reduce the risk. And then we've personalized it because not everybody has a high risk. So we developed a model, one of the models here that incorporates, this is actually a pre-transplant model to predict recovery after a liver transplant. And if you include age, diabetes, serum levels of osteopotin and TIMP1 before a liver transplant, it has a fairly good accuracy in predicting reversible kidney injury after a liver transplant. And this may be important for SLK selection. There's a potential to utilize it in that way, or renal sparing measurements in patients who are not predicted to recover. And we tested this, so that was our initial paper, and then we tested it with Dr. Samit Asrani's group at Baylor. We tested the same model in their patients, and we found very good prediction in serum and validation. And so this may be a model that could be used in the pre-transplant setting to enhance our prediction of recovery after a liver transplant or selection of SLK versus liver transplant alone. What about post-transplant markers in the blood that could detect early signs of kidney injury? We found some proteins, a 16 injury panel, renal injury panel, that were different in patients who actually had CKD after liver transplant than those who didn't have CKD. And we took these proteins and we tested them in our CTOT-14 study, which was a multi-center study collecting biomarkers for rejection and kidney outcomes in nearly 200 liver transplant recipients. And there were the cohort of patients of liver transplant recipients that had normal kidney function at about month 3. And there was a trajectory in the red of those who declined over the course of the study over 1 to 2 years versus those who maintained kidney dysfunction. And what we did is we tested a biomarker panel at time point here, which is about 3 months after transplant, to see if we could predict either one of these groups. And what we found was two proteins, beta-2 microglobulin and CD40, along with hepatitis C positivity, could fairly reliably predict the group that is going to deteriorate renal function. So if you have high levels of these two markers, there's pretty good prediction that you'll be in the group of deterioration, assuming you're continuing on the same immunosuppression, because the immunosuppression in these groups was fairly similar. We also looked over time, and there was a correlation with these proteins with GFR over time, not only beta-2 microglobulin, but some other proteins. So there's a correlation in these markers with deterioration in renal function. We then again tested this group at Baylor with working with Samitas Rani, and we were able to validate this PRESERVE model, which is a post-transplant model at 3 months that could predict deterioration of renal function at 1 year. But in Baylor, they also had 5-year data, and it was also predictive, and also with measured GFR. So this model is very interesting, and we're going to be applying it to a future grant, which we're working on right now. So we could transform these biomarker validations into clinical practice. So the reverse model is the pre-transplant model and may help with SLK versus liver transplant alone decision-making. We don't know if this really predicts kidney recovery in those who are in the AKI to CKD transition before transplant. We only used it in acute kidney injury. And for PRESERVE, the idea here is we have patients with relatively normal GFR after transplant. And if they're positive, they have above the cutoff, maybe consider CNI minimization or withdrawal proactively to avoid the deterioration. And or if they're negative, they may be in the group that doesn't deteriorate, and you avoid the risks of minimization when it may not be needed for this purpose. And we're working right now, we have a new CTOT study, CTOT CA43, where we're actually using some the PRESERVE test, and this is under development right now, to select patients who are positive for CNI withdrawal in favor of everolimus. And we're going to randomize patients to this group of CNI withdrawal versus continued reduced TAC and everolimus. And there's a test that I'm not presenting here, but TrueGraph Liver, which is being developed to, and we're going to use it to detect rejection in those weaning off tacrolimus, to be able to avoid rejection and all the things that happen from rejection. And so we're trying to increase the success of withdrawal of tacrolimus. So moving on to treatment strategies, kind of heard from this UO1 study, we're planning that we're interested in mTOR inhibitors and the ability to replace CNI therapy or minimize the toll of CNI therapy. And when you look at the randomized controlled trials of CNI inhibitor minimization or withdrawal after transplant, the benefit is mostly early afterwards, between 1 and 6 months after. All of these studies here, which are basically either combining an mTOR inhibitor with a minimization of a CNI or a complete withdrawal, or there's some arms where there's complete withdrawal of CNI therapy. They've all basically shown that if you completely withdraw CNI therapy, the rejection rate goes up fairly significantly. But those who escape rejection, which is the vast majority, 80–85%, they have the best kidney function all long term. And so the idea behind the biomarkers would be to help detect patients who are developing rejection with a CNI withdrawal, and that's what we're going to be doing in our UO1, and be able to not increase the rejection rate, but improve the ability to wean off CNIs using rejection biomarkers. More to come there down the road. I'm sorry, this is a little bit blurry, but these are randomized trials of CNI minimization after the first year. And so if you wait too long, there's really little benefit from converting to a mTOR inhibitor. There's some benefit of continuing mycophenolate mofetil that over time to just kind of minimize the CNI and use MMF. There may be some renal protective effects of MMF But long term, once you're after a year or two, there's really not a lot of interventions that have worked. And then finally, we have developed through some guidelines from about 5-6 years ago, protecting the kidney after liver transplant, some guidelines that were borrowed from the KDIGO management of chronic kidney disease. Alex Weissman helped put this together, and there's some, I encourage you to look at the paper. Sorry, I don't have the reference here, but it basically goes through some potential specific management strategies in liver transplant recipients. Unfortunately, none of these have been proven to be valid, but should be helpful in this population because they work well in the CKD population. So in summary, I'd like to just make some final statements about this. Renal function preservation is of utmost importance, along with many of the other outcomes. It does correlate very much with morbidity and mortality. So preserving renal function leads to better outcomes in liver transplant patients. Predicting who is going to develop CKD is very challenging down the road. We know patients who already have it coming out of the transplant, but those who don't have much kidney problems are at risk for developing future CKD. And this is where biomarkers may be able to help, some biomarker models. And this is a robust area of research. And I think using tools like that to be proactive rather than reactive in liver transplant recipients really should be the goal here. So thank you very much for your attention.
Excellent. Thank you to our speakers for their fantastic talks today. Those were outstanding. For those of you joining in the audience, please participate in the panel discussion. You can do so by submitting your questions in the Q&A tab on the upper left, and I see some of you have already done that. And with that, I'd actually like to kick off our Q&A with a question I'm going to direct towards Dean, but would like to then open up to the whole group. And I'm going to combine two questions. I guess basic question is, what can we do early post-transplant? And the question is, are methods to improve renal perfusion with pressors like terlipressin reasonable early post-transplant, since we know portal hypertension doesn't necessarily immediately resolve? And what role, kind of piggyback on that, does albumin play in kind of having the same effect with as far as clinical outcome?
So thanks, Michael. That's a very good question. The short answer is, unfortunately, there's a paucity of data for either of these. So, traditionally we would probably kind of target a map of 65 after transplant in somebody that we're not necessarily directly doing it for AKI, just because the assumption is obviously the physiology, although not totally correct, it is different post-transplant than pre-transplant. The second question with albumin is also very challenging, and as you're probably aware, most transplant centers tend to be fairly aggressive at using albumin, certainly pre-transplant. And while there is kind of good evidence for large volume paracentesis and HRS and SBP pre-transplant, there really isn't good data for using it per se post-transplant. And we also know from other studies that we don't tend to target a specific albumin level either.
I was just going to comment that this is I think theoretically something that should work early on. But, the difficulty is, again, having studies to prove that with other nephrotoxins on board and really having a clean group to study. The other issue is some of these patients do have sort of a rapid reversal or even go into heart failure. That tends to be a little bit later, a week or two after transplant, but we just had a case of Takatsubu's cardiomyopathy 5 days after a liver that, vasopressor therapy wouldn't be good. It's afterload reduction really and diuresis. So, but I think there's something to it. It just would be really hard to study.
I think the other concern would be, Josh, is immediate post-op. Sometimes yes, they come out on pressors, but a lot of times they come out and within less than 24 hours, they have blood pressures already on their own 150s, 160s, and their
Yeah.
platelets are so low. We've had a couple of kind of, bleeds, um, you know, um, intracranial bleeds, so that we actually now really very quickly sometimes put them on nicardipine or clavitapine, because again, it's kind of like in my other world outside of inpatient, I manage hypertension. So it reminds you kind of a pregnant patient. They're so, if they're used to a blood pressure of 80, 90, this sudden going up to 140, 160 actually is not really, I don't think they can tolerate it. So I think then, adding, because our surgeon also asked me about terlipressin post-op immediately, whether it would have an effect on the AKI, but I think my concern would be the blood pressure suddenly going up post-op.
I think these are very different patients post-transplant, I think is the take-home point.
One question I'd like to ask to the group, and maybe start with Dean and then also Mitra and Josh, is the donor selection question, right? So that's what we see on the liver transplant surgical side, these patients with some chronic kidney disease prior to transplant. And Dean, you had mentioned about, older donors, maybe some steatotic donors. Sometimes we're in a pickle on the surgical side. We see someone sick, we see a suitable liver transplant, and we want to accept that organ. So the question is, what comments do you have about donor selection in these sick patients from your perspective? And then the second one is on the SLK side, right? Kind of like higher KDPI kidneys. Should we be putting kidneys in patients that are SLK, KDPI 90, but the liver's a good liver and they're kind of sick? Are there situations that we should just transplant the liver and not do the kidney? So those are the two questions on donor selection. Maybe Dean, you could start if you don't mind.
Yeah, so those are very good questions. So with the liver alone, to start with, this is a real challenge that I don't think anybody. You're always weighing the risk benefit of waiting for a better donor, but how much time do you have that you can support the patient until they become unsupportable? So I kind of mentioned tongue in cheek the marginal donor, marginal recipient, marginal outcome. But in reality, we always make these difficult decisions. So one example is obviously if you could avoid a DCD, an older DCD, for example, in a patient with AKI pre-transplant, you'd probably do that. But ultimately, it really also depends on your region, how commonly how often you're getting phone calls for potential donors. So in an ideal world, if you could pick a non-marginal, non-extended criteria versus an extended criteria, you're going to go with the non-extended criteria. But in reality, as you mentioned before, it's always going to be a case-by-case decision because often we don't know what's coming if we decline. The second question, I think what you make is a very good point, that in a high-risk patient, generally it's probably favorable to do a sequential liver kidney where you do the liver to start with. And we know that there are theoretical concerns of immunogenicity if you're taking two organs from two different donors. But the reality is if you're getting through a really complex operation where they might need a lot of blood products, you're probably better off getting through that perioperative phase and potentially delaying the kidney, where you can make a better decision. And often you can temporize the patient on dialysis for a couple of weeks if necessary. That would be my thought.
I could, Mitra, if you don't mind, I can just provide a few additional comments. I agree with that. I think we could spend an hour on this topic. But I think there is a greater appreciation, as you've shown, of the donor quality and the impact on not just the liver, but I mean, it's related AKI after liver transplant. And this is where I think machine perfusion can really be beneficial, because you could have the opportunity to evaluate the liver function, perfuse it, reduce the inflammatory cytokines that probably contribute to AKI. So our preference has been to avoid really high risk donors in high MELD patients, understanding that it is a ticking clock, but the last thing you want is not a good graft, not a good kidney function after, and doesn't serve that patient or the organs well. For SLK, we had some. There's been a number of studies that had shown not very good outcomes if you use and they were previously called kind of extended criteria donor kidneys. And actually, when you do a liver kidney with one of those, they often don't work very well in the end. So again, I agree with I think a more optimal kidney is going to lead to more optimal outcomes. It's easier said than done, though. If I think in people where you're clearly convinced that they have chronic kidney disease and aren't going to really, somebody who's been long standing on that, they need a good kidney. In patients who are in sort of the prolonged AKI, or they meet CKD criteria, but it's sort of soft from the SLK criteria, then maybe putting in an additional kidney, but hoping that some native kidney will return too, to combine with those may be beneficial. But tough question though. Mitra, I'm sure you have some comments.
Yeah, I just wanted to add a couple. I think a lot of this has to do with the region. I think with the safety net, it kind of has allowed our surgeons to be, maybe in the past they would pass on a liver if the patient needed a liver kidney, they would kind of pass on it if it wasn't an optimal kidney. I think now, if the liver is good and the kidney is no good, because of the safety net, they may go ahead and just, use that liver for that patient, knowing that in our region, in region 5, the wait time is so long, especially at blood type O, versus, if it was AB or B, it would be different. I think the problem, however, that we're kind of seeing, that was my biggest fear, and I see this is slowly happening more and more, is that you have that patient where they you thought they would meet the criteria post-op for an SLK, but their GFR is 21 or 22, and you're at the end of the year, and the hepatologist has brought the immunosuppression so low to avoid it, and it becomes a problem because now they're going into a year with this GFR of 21, which we know is not good, and after the year, they're going to sit on the wait list. I agree with Josh that if they have because again, these CKD criteria for the SLK is a bit iffy, in my opinion. If you have someone who has a GFR of, 50, and then for 4 days is on dialysis, they would potentially qualify. And those patients, if you give them a kidney that may not be the best, you just kind of hope that the native will kick in. But it's a very tough question, I think. And again, each region, I think that's why we can't collectively even collect data, because each region has their own problems with, number of donors, number of, centers, how many people are fighting for that. But I have noticed that we do a little bit more liver transplants, with the hope that, with the knowledge that knowing that there's the safety net. But this negates all the studies that's, from the surgical people saying, those first 3 months are critical. So we have people who are 3 months now on dialysis post-op because they didn't get the kidney and it just never, got better. So it's very, very challenging. I think that's where the biomarkers, it may not be able to answer all the questions, but hopefully it will kind of help us a little bit more than right now, which we have basically nothing to decide on these things.
Yeah, those are excellent points. I know anecdotally at our center, Mitra, we're dealing with the same issues. I had kind of phrased a question for Josh, but I do wonder if we're kicking the can down the road a little bit. So our SLK-KT policy looks good initially, but now we're going to have this delayed impact in patients who miss that window. Mitra, I'm gonna pose this question for you, but then open it up to the group. We discussed a little bit timing of renal replacement therapy pre-liver transplant, and I think there's some cases where it's clear cut, but we all have patients where it's equivocal, and we're debating if we should or should not start dialysis and when we should do that. And a lot of times we're on the side of earlier initiation because of the short-term impact on the MELD and getting them transplanted. And I'm just curious, is there any potential harm to that, you think, and then post-transplant renal recovery for those patients where you're using the renal replacement just as a bridge to transplant?
So that's the million-dollar question, timing. If you look at the non-cirrhotic literature, there's now been like 5 or 6, New England Journal, Lancet, JAMA articles looking at timing early versus late. But I think they're extremely flawed in the sense that, the patient population that they're selecting, they've screened 3,000 patients just to get their cohort. And no one talks about that 3,000 that failed, randomization. And a lot of them were fluid overloaded, hyperkalemic, and things like that. And they all exclude liver patients. For the liver patients, we looked at our own data. This was back in 2008 to 10 when we had a very, high mortality rate on our SRTR data. And I pulled out that data and we actually published. And since then, our practice actually changed. And what we found is one of our highest mortalities had to do with patients who pre-transplant were fluid overloaded and who went to the OR intubated. And they had the worst outcome, not only intra-op, because they were going in with high CVPs, high wedges, and then boom, all of a sudden reperfusion, they would have, go into right heart failure and die. We also had a lot of post-transplant, trying to get them off the vent. They would get then pneumonias. So around, since we analyzed in 2010, and that was when Dean also does a lot of, I guess, ICU outside of liver, but that's when the trends started happening with non-cirrhotic patients that fluid overload is bad in the ICU and to become more and more aggressive. And I just took that, knowledge and our data and I implemented it for a liver patient. The problem is that people suddenly jump, oh, they're dialyzing patients for the MELD, when in fact, no. If you look at the critical care literature, fluid overload is bad. So in the past decade, I can tell you that except for our ALF patients who, develop encephalopathy, maybe 1 or 2 who have dense encephalopathy, we no longer have any patient going to the OR intubated, and they get extubated very quickly. No trachs, nothing. Whether it harms the kidney, I personally don't believe that. We often do CRT. Yes, if you do hemodialysis and you're constantly dropping the pressures, it may have an impact. But there's no data to support saying that that if you start someone on dialysis versus keeping their creatinine at 6 is going to make it, it's a worse outcome. I think in a liver patient, a creatinine of 2.5, 3 is basically dialysis. But I do believe that keeping them on the dry side, keeping them, not getting intubated. If they get intubated, it's the kiss of death for many of them because they're so weak they can't even get extubated. So we err on the sooner side. We do have guidelines. I don't look at creatinines. If they have anasarca, I hit them with diuretics. I don't do the stop diuretics, give albumin, because they already have declared themselves with anasarca and AKI. So I hit them with diuretics. If they don't respond, and response means to keep themselves quite negative in a day and not run into issues. We usually run into big problems with hypokalemia and sometimes with hyponatremia. Then I, recommend, we have guidelines and they go on, CRT very quickly, quick eval. If they're not, then we de-escalate. But I don't go with the, HRS protocol of give albumin. I think this was one of the problems with the terlipressin trials, that I believe they had a lot of people who were already fluid overloaded, went through the HRS protocol, and then just, tipped over when you gave them something like terlipressin. So I believe if they have anasarca, really, if you can't remove it with diuretics in 24, 48 hours, you need to kind of get the fluid off of them very quickly.
I would want to.
They also get a lot of They also get a lot of gut edema, and on top of the lactulose, we've had, again, in our own data, we had a lot of people with really, really bad ileuses that, ended up perforating. So again, we're very aggressive with fluid removal.
Yeah, I just wanted to add to that, and I think we're seeing much more and more um, a kind of less recognized etiology of their AKI, which is cardiorenal syndrome. And I think that's basically what Mitra is describing, is they're patients who are fluid overloaded, high central pressures, but they're not really acidic fluid overloaded, they're total body overloaded. And actually the right thing to do is to aggressively diurese them. And that actually they can improve their kidney function. And I think it's under recognized. We look at this and we think it's all HRS and give fluids and then give terlipressin, but actually when you see that situation like that, it's aggressive diuresis. They usually improve. If they don't, I think you've got to do dialysis, CRRT, and I think I'm sure David will agree. Going into the operating room, it's very challenging to go in. You wouldn't want to go into the operating room in someone with high central venous pressures that may have marginal, not the best cardiac function too, and liver gets congested, the liver may not work, all sorts of things, AKI. So I think getting control of that situation going into the operating room is the most ideal.
Mm-hmm.
I agree wholeheartedly, Josh. It's always better to have that fluid volume down, CVP 8-ish, 9-ish, not 22. They can tank the patient up when we have to, cross clamp the vena cava, so they can maintain some stability. But no question, we like to have
less bleeding too, right? Less intraoperative bleeding. Yeah.
We don't like to see right heart failure either, for sure.
Yeah.
I have one question. Mitra, maybe you could start, Josh, and comment. The whole CNI minimization after liver transplant. I know it's inconsistent across a lot of centers. What guidelines can you give the people here in terms of when AKI having issues on CVVH? When do you initiate CNIs? What's your management within the first week? And when is it safe to go ahead and start it thereafter?
I'm just a general nephrologist, so I'm going to
leave that up. You want me to comment?
Josh. Go ahead, Josh. You can go ahead.
Yeah.
Well, I think I'm quite convinced by the data on even though the populations that were put into delayed and reduced CNI were mainly patients who didn't have AKI. But if you kind of extrapolate it to it, the data would probably be even stronger. So if we have anybody like this who is not meeting SLK criteria yet, that maybe in the past would have received a kidney transplant, we give them basiliximab induction, and then we delay their tacrolimus until day 3, and we shoot for 5 to 8 levels, and we use mycophenolate. And I can tell you, we've had it does give the kidney a real break, I think, not starting the CNI right away. I mean, the mechanisms of renal vasoconstriction are very potent, as we talked about. They still have kind of somewhat of an HRS physiology, and so they're really at risk early on. And I think it's very helpful, and I think the basiliximab covers them. Whether that translates to long-term GFR benefit is a little bit less, because you get a benefit early, which usually should translate to late benefit, but not always, and because there's lots of other factors. I kind of view these patients, I think the wrong thing to do is to just turn around and their kidneys recover and then just blast them with go off a real renal sparing. You can maybe go up a little bit, but they've shown that their kidney's at risk, and so we kind of use a little bit lower targets, MMF, and then we're a program that often uses reduced TAC and everolimus if it's safe after a month, to try to have a whole renal protection profile. To really, the ultimate is to avoid the early dialysis where they need a safety net, and also avoid long-term CKD. And can't say it always works, but I do think that's a good strategy.
I think one helpful thing also would be in patients, because, and maybe, because Josh does a lot of biomarkers, it's not the patients who already have AKI, but those who are coming from home or are live donors. I really think there would be a benefit of doing immediate, a check of biomarker as
Yeah.
they come out of the OR, because I think the creatinine looks okay with all the fluid they get in the OR, and we're getting AKIs 2 days or 3 days later because the surgeon just gave them normal doses of cyclosporin or Prograf. And so I think that would be very key to start, and that's what the cardiac surgeons are targeting. They're doing immediate biomarker with the NephroCheck that's FDA approved. And if anyone has, a hint of, that there's going to be a problem, they suddenly change their post-op management of that patient. They hold off on scanning them. They hold off on various medication. And I think for the liver patients, especially since a lot of patients in the nation are coming from home, normal kidney function, which we assume is normal, and post-op they're getting AKI, to be able to prevent those, I think would be ideal with a biomarker.
Hopefully we can develop more research studies and test them in real time. So,
well, unfortunately,
that's
we're going to have to end it there. This has really been a great session. I want to thank our speakers for a wonderful session. Also want to thank Michael for organizing this with me and moderating the session. It's been really great. For the audience, you'll now see a link to the surgery, the post-test survey on your screen. So be sure to complete the brief questionnaire to receive your CME credit. And we'll now take a 30-minute break. Please take this time to visit the meeting sponsors in the exhibit hall. And then be sure to join us back here in Theater 1 for Session 4, Defining and Achieving Success Through Minimizing Infections, starting at 1:45 Eastern Standard Time. Thank you, everyone, and have a great day.